as of now, strangulated hernia, there is no recommendation for laparoscopy as a method of choice. Laparoscopic approach is not a panacea. It's unsuitable for large scrotal hernias, can't deal with the large inguinal canal lipoma, and it is not necessary really for a Nyhus type 1 hernia. And females in active reproductive life, if you stuff in the lower abdomen with a large mesh in the later months of pregnancy, it can prevent normal distension of abdomen. I've seen 2 patients struggling to breathe. And periperitoneal repairs cannot or should not be done on patients undergoing vascular surgery, that is iliac surgeries, lymphadenectomies, urogenital cancers, other pelvic cancers, bleeding disorders, and those with previous additions. Do you want a general anesthesia which is generally required for all lap repairs, or with all the systemic effects of GA, hypercarbia, and the extremes of triangular position that we gave, or just a local anesthesia? So most open surgeries, open hernia repairs are day care surgeries today, unless the patient wants to stay for his reasons or the physician wants the patient in for his reasons. Laparoscopic surgeries usually involve general anesthesia, so at least a day's admission is required. This pushes the cost in favor of open. I'm not talking of India alone. Even in UK, the cost difference is $300+ pounds. US, it's about $1,000 on an average, and Canada $500. This is reported by the Journal of SLS, October 2014, not old. And it is suggested that hypothetically, you shift 1,000 patients from TEP to open Nyhus repair, you could probably save $200,000. This is reported in 2013 in surgery endoscopy, the potential saving to the healthcare system. That means laparoscopic repair needs a selection of patient, selection of surgeon, selection on financial consideration. It may not be ethical, and readiness for an open conversion. That means there is no laparoscopic surgery without open option in your pocket. And on the other hand, open repair gives you a menu card of surgery, which is onlay repair and preperitoneal repair. Professor Thomanas was concentrating only on this. Just one more minute. So you choose between a Mercedes and a workhorse like a Jeep. Most of the times, if you have a good road like this, yes. But what is the reality? You have a Himalayan terrain, most part of the developing world, and you can't do that. You have to go for an open surgery. So because it's not a new concept of hernia, it is application of a new technology, the refined technique involving technology, technique and training, unfortunately available to a limited few, leaving a large set. So this is the open hernia menu. It's not just leaving out the tissue repair like Bessini, it is a big menu of availability: anterior Lichtenstein, posterior Nyhus, Stopa, Henry, so many. Everything, every open procedure shuts the MPO. It is not just an onlay alone. Onlay is one type of maybe most popular open repair. Homerton Hospital, UK, 500 bed strength, 212 open versus just 65 open hernias. British Hernia Society recommends for unilateral as well as elderly people the open procedure. So that means even in India, open repair is all inclusive solution by laparoscopy. This is a personal survey I did from about 15 medical colleges across the country. It's overwhelmingly open surgery. Just about 10% are done laparoscopically in teaching. I took a survey from about 30 personal survey from 30 odd surgeons in pure private practice. It is all open. You have to about 2 to 4%. So as of today, open hernia is the best because it is safe, secure, versatile, offers the selection of procedure, it saves a failed laparoscopic attempt, it has a cost benefit and can be employed in high risk cases, and the expertise is more easily attainable, available to every ordinary surgeon, and I have no doubt to say open hernia repair is the best. Thank you.